Hello everyone. Welcome to another session of Zooming through ID. I am Dr. Gopal. I am an infectious disease physician at Broward, trained at Duke University, been practicing for more than 20 years. I'm the chair for antibiotic stewardship and also medical director for infection control. I'm the associate program director for our Infectious Disease Fellowship program. When internal medicine residents rotate with me, they pick a topic of their interest, and Zooming through ID is a time where they can showcase what they have researched. Today, I have Dr. Janice Gomez with me, and I will let her take over. Janice,
Hello,
yeah.
everyone. Hi, Dr. Gopal. Nice to be here. Thank you so much. My name is Janice Gomez. I'm a PU1 internal medicine at Broward Health North. Super happy to be here and be talking today about this super interesting and important topic of syphilis. So I'm gonna share my screen to get this started with. Let me see. Here we go. Let me see. Um, Open, sorry, it's giving me some trouble here. Uh, it's not letting sharing me, not letting share the screen, not sure why. Let me see. Share, can you see my screen? Hello? Can you see my screen? Continue to
There
share.
you are. I see it. The
Okay, perfect. Sorry for the little
Great.
So, okay, perfect. Okay, so let's get started. So we'll be talking about today the syphilis, very interesting, important topic in infectious disease. Like I said, my name is Janice Gomez. I will be presented today, PU1 in Broward. Um, so a little bit of overview of syphilis. So what is this? So it's a bacterial infection that is caused by the Treponema pallidum, a spirochete, and spreads usually through sexual contact and also from transplacentally from the mother to the babies. And a little bit of history about syphilis and how it got discovered, what is important, statistics. So syphilis used to be a very like huge major problem of public health. And in the mid 1900s, saw a dramatic decrease, sorry, due to the development of what we know of the first one of the first antibiotics, the penicillin, the discovery. And in the recent decades, there's been a huge surge of this, recurrence of syphilis again, even though this is very easy to treat. And because of this, it's important public health problem that we need to address, and especially in countries like the US. In 2020, there was a big peak in cases of syphilis. Um, and basically, the importance of this relies that untreated syphilis can lead to severe health conditions, especially when left for a long time in the body, like what we call latent. I will speak about that later. Latent can cause problems with the heart and the brain, even death. So this is mostly important, and also because of the congenital syphilis, the transmission to the babies that can happen, that can also be mortal for them or living with very bad comorbidities, these infants. And the prevalence in the US has been rising, like I mentioned before. And the statistics in the studies that I found says that there was a rise in about 26% from 20 to 2021, which is super recent. And in congenital syphilis, there was a rise by 24%, super worrisome. So the current statistics that I was able to find more recently, 2016 to 2020, um, marked this like resurgence of like syphilis. And over 70% of resurgence, of increasing cases between these years. So it's mostly like 4 years, apart. And it's crazy to see such a dramatic increase. In 2020, the studies demonstrated that there were more than 130,000 reported cases of syphilis in the US, and that's the highest number in 2 decades. Usually, what they see populations that are more disproportionately are men who has sex with men and people living with HIV. Key data that is important from these statistics is that about in 2020, about 41,000 of the cases were primary and secondary syphilis. And why is this important? Because this both stages are the most infectious of the disease. So people are transmitting this. All these people, if they were having a partner, that means this will be like the double because the partners are getting it if they were not getting protected. And also in regards to data for congenital syphilis, that transmission basically increased by over 200% based on the studies. So super worrisome these statistics during these 4 years. Some factors that the studies mentioned that are contributing to this like epidemic are four key things. There are many, but these four were the most like important. So changes in sexual behavior, basically a lot of people having more unprotected sex, more multiple partners that we've been seeing through the years, people also with higher rates of casual sex, declining also public health resources because the fundings from the government has been being reduced in regards like prevention of STDs, outreach programs, to arrive to these communities that sometimes are in lower economical stage or lower educational in the social aspect. So this resources of public health have been also declining. Also, there's a stigma, super important, because when people have a stigma, they underreport, so they avoid seeking the healthcare. They stay with this infection through these different stages, and it causes a problem. And there's also lack of awareness and education. Also, increased risk, like I mentioned in this. Um, Populations with limited resources and access to healthcare and to education. Other than that, now let's talk a little bit more about the pathophysiology. Why is this transmitting so fast, right? And what does it happen? So basically, the mechanism of the disease is very easy. You have this bacteria, a spirochete, that there's a break on the skin, there's sexual contact, there's a mix of the blood with the mother of the child. It just has to be a penetration of the mucous membranes. Penetrates the bacteria penetrates the mucous membranes, multiplies locally in our lymph nodes, in our body, goes to the lymph nodes, and from the lymph nodes spreads to the bloodstream, from the bloodstream to our organs. So the two major routes that have been identified, the sexual and the transplacental, and the issue with this is that when this happens, it gets transmitted, the infection papule, which is the first stage of syphilis, the first, like, let's just say, sign that the person will see physically, is sometimes it takes like 2 to 10 weeks after the infection to actually being seen. So we'll discuss this more in detail on the further slides. So in this one, it's just a summary so you guys can have like an idea what happens through all these stages with this infection. So basically you have the inoculation, the organism spreads. You a couple weeks, maybe like a period of incubation, 3 weeks, 2 to 10, you can have then this sign, which is the first primary syphilis sign, like the chancre, what would they call the chancre. You see it physically, but then the people can have that we're going to speak about this in more detail, but there's an asymptomatic period, then secondary syphilis, then it stays latent in your body if during these other stages is not treated, and it can, come back basically like a reversion of the stage. And this over time can lead in many years through tertiary syphilis. So let's start discussing a little bit more about that. First, the clinical presentation. So these are the stages like we were discussing. We see here that usually you get the exposure 3 to 4 weeks, you get the primary, and that might happen between 3 or 6 weeks. So this is like the addition of we're talking about 2 to 10 weeks. Okay, so the average time from exposure to developing the symptoms can be about a month, let's just say it. Then from stage 1, 2, 3, typically they're separated by periods of no symptoms. So that's the grayish area here, okay? So it's like the symptoms disappear for saying like that. So the person gets the chancre, it disappears, and then they think they don't have anything, right? That's a problem. And there's a prominent phase then later, which is the latent, which after secondary syphilis happens between the secondary and tertiary state. And we'll talk more about that. Is the most highly and contagious stages are the primary and secondary, like we mentioned before, and some part of the early latent also is can be highly contagious. Um, Let me see. Okay. Let's talk about a little bit, sorry, about symptoms and impact. So now we're going to start describing and seeing each of the stages. But in general, primary syphilis, we're going to characterize it like the chancre, the appearance of that. It can be in the any part of the genital area, anal or oral area, any mucosa. Secondary syphilis will come more with the rashes that they mention a lot, flu-like symptoms, B symptoms, fevers, swollen lymph nodes, and things involving more the mucous membranes too. And latent syphilis, this stage, there are no symptoms at all because it's just living there in the body quietly, but can reactivate and can go back to what is, the rash, the lymph node to the secondary syphilis stage. And tertiary syphilis, many years after, you will see how, if untreated, this condition will get severe, affecting the major organs, heart and brain, heart, brain, nerves, a lot of them, but heart and brain being the majority of them. So these pictures, I really like them because they're portrayed. I'm gonna show a couple of them, like very well the characteristics, the physical exam that we can find in patients with syphilis. So primary syphilis will get the chancre and the regional lymphadenopathy, and secondary syphilis will see the constitutional symptoms, and we'll see the rash, okay, the polymorphic rash on palm and soles. You don't see it here in the picture, but you see in another one. Also, it can happen in other parts of the body. You'll see the mucosal involvement, tertiary syphilis. You'll see more mucosa and organ issues. And in any stage, with this was particularly curious to me because I thought like neurosyphilis that can happen mostly at the later stage, in the tertiary, but seems like neurosyphilis can also happen in any stage. So things to look out for, okay? And involvement of the eyes and the ears. So I didn't know that before. I did this research. So super interesting. All the involvement that this.
Yes, that is very important. I mean, I'm glad you're telling, you researched and you found that any stage, the neurosyphilis can occur. And also, one point to mention is for ocular and otic syphilis, the LP may be negative. Um, that is also something important to consider. So, as soon as the patient is infected, there is a chance that it can become neurosyphilis, especially immunocompromised. So
Oh,
wonderful.
awesome. Thank you. Super interesting. So here's a little bit about the second stage of syphilis, which we have like the what we talked about, the mucous membrane, the rash, the generalized lymphadenopathy, once again. Here the tertiary, a little bit more detail. So the progression of the disease can affect all the mucosal. You can have gums in the skin and the bones. You can have neuropathy. You can, because of the tabes dorsalis, the involvement in the spinal area, In the cardiovascular system, we can see cardiovascular syphilis, which affects the aorta, giving you a aortic ascending aneurysm because of the way that this infection debilitates the wall of the heart of the aorta of the arteries. Also, the involvement of of the ocular part that we were talking about and the brain causing dementia, changes in personalities, altered mental status. So super important this stage. And I added here a little bit about the congenital syphilis stage because it's important to recognize this in babies too. The most important thing, basically early on in the first 2 years of life, you can have these symptoms. So bone abnormalities like jaundice, the rash in the palms and soles, desquamation, rhinitis. So it's a very have a lot of involvement in the body for the baby in the first 2 years of life, and even later in life. The most like prominent symptoms or physically things that we see in physical exams that are always tested in boards is the Hutchinson triad. You have the interstitial keratitis in the eyes, the sensory neural hearing loss, and the Hutchinson teeth. So super high yield for boards, this part here, this triad, and it usually occurs a little bit later after 2 years old. In regards symptoms and impact, so mostly kind of the same thing, right? So these early symptoms, like we discussed, untreated syphilis, given severe complications in the major organs, and the congenital causing more severe, like birth defects, like also like stillbirth and infant death, because of these complications. The impact fatalities in the final stages of untreated syphilis. Obviously, if you don't treat it for many years, can be fatal because of all the organs involvement. Also can cause prematurity for the congenital one, birth defects like we talked about already, and disabilities. Um, so super important disease in the infectious area. So we need to see how we're going to approach it. When we have a patient that we suspect or is at risk of syphilis, there's algorithms that are made to see how we can test for it and then treat it, if so. Okay. So there's these tests that I wanted to mention before going to the algorithm, so you guys can know them first. So there's serologic tests. That is the non-treponema test, the ones that we know, very common, RPR, and the Venereal Disease Research Laboratory, the VDR. So these detect antibodies produced in response to the cellular damage, okay? Not to the spirochetes, response to the cellular damage. So that's the non-treponema one. The treponema test does, which is the TPPA or the enzyme immunoassay, these do detect antibodies specific to the spirochete, okay? So non-treponemal antibodies to the response. Treponemal test antibodies to the bug, the bacteria, okay? And also, those are the serological. There's also forms that we can see directly the bacteria with dark field microscopy, which will confirm the syphilis, and also directly we can detect with PCR. Okay, so this we do it actually usually from the lesion. So we get a sample from the lesion, and these can confirm it. And like the Dr. Gopal mentioned, the CSF is something that we usually do, and indicates if neurosyphilis suspected, then you'll see like increase in white blood cells, protein, things like that. So here's the algorithm that we're gonna discuss. Let's zoom it out a little bit, but it's a really good algorithm, easy to follow. So we start with the features, right, of the candidate that we're gonna screen. A person that is at risk or that comes because they say like, hey, I have this symptom, this or that, and you're suspected, right? The chancre, the rash, and you suspect it. So you have two choices. Usually, I've seen a lot in the hospital. We start with the RPR. which is a non-treponemal test. But depending on the laboratory and certain hospital, they might start actually with the treponemal test, the other serological one. So let's just follow the algorithm first for the one that I've seen most used actually in Broward. So we do the non-treponemal test, which is the RPR or the VDRL. If that comes back positive, then we have to do a second test, which is the treponemal. So you have to kind of like follow with the non-treponemal with the treponemal, okay? And if that's positive, then the patient likely has or current syphilis or likely had it in the past, depending on the presentation. If negative, the patient, this is the first test, is a false positive. That's what it means. So that means that if the treponemos is negative, the non-treponemal initially was negative. And what you don't usually ignore it, you repeat it again in 2 to 4 weeks to make sure, okay? If we continue, go back to the algorithm, we do the non-treponemal test, comes back negative. We'll talk a little bit further about what happens when it comes back negative. But let's start on the other side, which is the reverse. We start with the treponemal test, which is the FTA-ABS or the agglutination test, the absorption one or the agglutination test, and that comes back positive. So you have the treponemal, now you have to do the non-treponemal. So confirm with the non-treponemal. When you go to confirm with the non-treponemal, if it's positive, then the same thing, current syphilis, or it's basically they're latent, you have it in the past. If negative, the same thing, you have to think it's a false positive, but check in 2 to 4 weeks again, okay? If any of these tests at the beginning, no matter with what you start, come back negative, you just don't ignore it either. You have to assess the risk status of this patient. Okay, is this patient high risk or low risk? You assess it based on what the patient told you about their sexual practices, their exposure, their everything. So if the patient is a low risk, we usually syphilis unlikely. So we might follow it like a regular follow-up in a primary care visit, maybe like a year STD panel. But if it's the patient is high risk, you cannot exclude it because they can be in one of those phases where they can be early on in the infection and that there are not enough antibodies to detect it and things like that. So you have to retest again, sometimes even treat, okay? So that's basically it, okay? Not too hard. So for preventions and strategies, so that was the way how we diagnose this. This I'm gonna talk about a little bit of prevention and treatment, sorry, a little bit very general, and then go deep a little bit in the treatment. So prevention strategies, obviously, counsel everybody in safe sexual practices, condom use, regular testing, partner notification and education, especially if a patient comes back positive, you have to report it to the health department. And treatment was very easy. In general, penicillin, but we're gonna speak about because there's ways that it changes based on the stage. Okay, we're gonna talk about certain details. So basically, this is mostly like the generalized concept. So to initiate antibiotic treatment, you have to confirm the infection, and if you still suspect it or still suspect like an early infection, then you have to like retest the patient, okay? What else? So if you're gonna start, in general terms, you're gonna start treatment, penicillin and all this treatment that we're gonna specify in more details. Penicillin has an important reaction that you need to let patients be aware of, like a secondary effect that the antibiotic can cause. And you might hear it before, you might see it in the boards as the Jarisch-Herxheimer reaction. And basically you have to let them know, hey, you're gonna take penicillin, you're gonna be started on this, but you basically the symptoms of the infection can worsen. For example, the rash can get worse. You can have like symptoms of like flu-like symptoms and things like that. So diarrhea, So you just have to let the patient be aware of these side effects so they don't, stop the treatment early on if they need more. So the screening is you have to screen for co-infections always, STIs like HIV, gonorrhea, chlamydia, everything, and evaluate and treat the sexual partner. Super, super important. Um, in regards more of prevention and treatment, um, other criteria like people, you have to talk to them, advise to them that they have to abstain with from sex until symptoms have resolved. When you start treatment, um, usually about 7 days that the treatment is completed. That's what I found in the literature. I don't know if Dr. Gopal can confirm that for me, but usually about 7 days after they should be good. Also, what else? They have to use the barrier contraception. If they have like confirmed titers, we have to offer counseling. All this general stuff that we do in the outpatient setting. In regards management, now we go a little bit more deep about the antibiotics, and we're gonna talk about like each stage, how it works, for how long. Okay, so first line treatment, benzathine penicillin. Okay, penicillin G, this is the one. So this is the amount of units, 2.4 million, that it comes in the intramuscular shot. Alternative treatments that we're gonna talk about, when do we use these. Usually for penicillin allergic patients, the option will include like doxycycline, tetracycline, and even in some cases, you can like even vaccinate. That's recommended to vaccinate the patient to what's the word? When patients are allergic, you can desensitize them.
Yeah.
Yeah.
Desensitization. That is one major indications in a pregnancy,
Mhm,
a pregnant patients. And one thing to one important difference that I have to mention is in terms of sexual transmission, you mentioned that, which is very right, primary and secondary stage. That is where the sexual transmission happens. But vertical transmission in pregnant patients can occur in any stage. So that's why treatment of syphilis is very, very important. And this is one scenario, pregnant patient, we definitely will have to desensitize them to penicillin. And that is quite often done and treatment to prevent the congenital syphilis because it is so devastating. Yeah.
mhm.
Mhm.
Wow. Okay, thank you. Okay, so here are the three. I really like this reference that I have at the end of my references. I really like this table because it like condenses pretty good during each stage. So the treatment guidelines mostly for primary and secondary in non-pregnant adults, including adults with HIV, so it's the penicillin G. You get a single dose of the IM, or there's also, if you cannot give it, but we prefer giving it with the desensitization, there's also the option for doxycycline, 100 mg orally twice a day for 14 days. That's the first alternative, or the ceftriaxone, 1 to 2 grams daily, for 14 days, IM or IV. I've never seen these two use. I don't know what's your experience with these, Dr. Gopal, but I think in the primary setting, we also always have all my cases. We always use penicillin, and I haven't had to use these yet. I guess it's for more like very severe allergies, or I don't know, people that doesn't get desensitized. If you can give
Yeah,
it.
penicillin is definitely the drug of choice, and that is what we usually end up using. And doxy, as you know, we cannot use for pregnant females.
Mhm.
And mm, ceftriaxone is an alternative, but the penicillin is still the drug of choice. And some scenarios, the allergy may not be true penicillin allergy, and so that's why desensitization becomes very important.
Yeah. Okay. And even like I would guess like maybe it's people getting like anaphylactic shock to penicillin. That will be one of the ones that you will might consider after the sensitization of these. But yeah, for sure penicillin G is the drug of choice. For latent syphilis in non-pregnant adults, once again, we still have the same thing. You got the single dose IM of the penicillin G. Sorry, for early and then latent. In latent, what I noticed is that they increased the amount of the units from 2.5 million to 7.2 because they administer like in 3 different IM doses and consecutive weeks. So I'm not sure if there's like any specific like like pathology behind this treatment, what they're given three versus one shot on the other ones. Because the literature, I couldn't find anything specific. And that
So
like
the
three.
early stages that will be primary, secondary, and early latent. That is the penicillin we give 2.4 one-time dose. But late latent, or if we don't know the duration, if it is unknown duration, we do the weekly injections times 3.
Oh, so that's why, because of
That is,
the.
yeah, late latent, and especially with the HIV patients and all, we definitely have to always stage the syphilis, and so late latent is the one there we do 2.4 times 3 doses. Yeah.
Okay, perfect. Yeah, because you don't know how many years they've been with it, so that's okay, super cool. And here they mention again the alternative of doxy, which we don't use much, but it was interesting for me to find it. And like we said, here is the 3 weeks I am for the late syphilis with the manifestation. However, not neurosyphilis. Um, for neurosyphilis, is different. For neurosyphilis with ocular syphilis, what I found is that you use this one, the aqueous crystalline penicillin G. The dose is much higher, 18 to 24 millions. You administer IV doses every 4 hours, this amount of units, 3 to 4, as a continuous infusion. This is in the inpatient setting, of course, for 10 to 14 days. Other alternative is the penicillin G procaine, which is a different one from the other one. Single dose IM, and plus you add the probenecid, and you also administer orally for 4 times a day. Both of those, 10 to 14 days. Have you had any other experience with?
Usually, we can send them home with IV penicillin treatment. If it
Oh,
is,
okay.
yeah, we don't. It doesn't have to be, 10 to 14 days in the hospital. I've
Oh,
sent patients home with PICC line, and they can get it in the
oh.
IV. Yeah, 10 days is sufficient. 10 to 14 days is the range.
Okay, perfect. Okay, very interesting because yeah, we can send the IV, but sometimes yeah, okay. The for primary and secondary and pregnancy, we have to use the penicillin G, single shot like the doctor mentioned, Dr. Gopal mentioned, and for the latent syphilis in pregnancy, we usually use the early latent, the penicillin G, one single dose, and late latent we use the 3 doses. Okay, so that's in pregnancy. It's kind of the same approach. Okay, here is a more summarized table. It's another one that I found. It's a pretty good one. I think this one is the one from up to date. So it kind of let's have more summarized the same intervals, the when we use it or not. The only extra thing that this one shows is that they use the ceftriaxone for the neurosyphilis as an alternative at some point. That was the extra information in this one that I wanted to
Yeah,
present.
that is also, and that's ceftriaxone is an alternative, and it's like second line regimen for neurosyphilis and aortic or ocular syphilis. And one point to make is CSF pleocytosis, and if there is a history and everything in the lumbar puncture, that is also highly indicative of neurosyphilis.
Oh, okay. Of neurosyphilis, yes. Okay. So after we give these patients like these shots of penicillin, we need to follow up. We need to repeat the VDR, the RPR, the VDRL between 6 months to 1 year. See treatment response, like you do it the earliest, obviously, but then like continue repeating. There's special considerations, patient with HIV, because you might need more frequent monitoring because they're more like at risk of getting like infected. And the complications that we can see is like cardiovascularly wise, aortic aneurysms, neurosyphilis, ocular syphilis, orthosyphilis, and congenital syphilis. I just wanted to mention again, like the most important complications that we want to avoid with these treatments. The preventions again, and the public health response basically is important. We need to increase the awareness of this disease, making campaigns, educating people. We need to expand the testing because it's such bad for the health and such like has such a mortality and morbidities. So many cases also through the US. So we have to prevent this. A lot of collaboration between all of us in healthcare and try to educate more the patient in our patient settings. Okay. So now in a few, we're gonna continue later in the next part of the syphilis, in which we will introduce a little bit, practice a couple questions that are high yield for the boards. So it was a pleasure and see you in the next one.